proteasome inhibitors have become really a key for treatment of myeloma, both in the newly diagnosed setting and in the relapsed and later refractory setting. The approved drugs right now are bortezomib and carfilzomib. In terms of new directions, there are a couple of oral proteasome inhibitors that are moving through clinical trials. One of them is called ixazomib, the other one is called aprozomib, and they have the promise of making treatment more convenient for patients. They wouldn't have to schlep back and forth for injections, because right now bortezomib can be given either intravenously or subcutaneously, and carfilzomib can be given only intravenously. The other interesting development is there was recently a trial that was reported, and we hope to hear more about the data at the upcoming American Society of Clinical Oncology meeting, but this was a study comparing head-to-head bortezomib with dexamethasone versus higher dose carfilzomib and dexamethasone. The carfilzomib was higher than the currently approved dose, and that trial was reported to show a superiority for the high-dose carfilzomib with dexamethasone, and this will be the first time that we may have some guidance about which proteasome inhibitor may be a little bit better. Right now, a lot of the treatments that are given are combinations, and probably the most common one that people use is a proteasome inhibitor with an immunomodulatory drug, either lenalidomide or pomalidomide, and sometimes thalidomide. We, for example, at MD Anderson have been involved in the study showing that carfilzomib with pomalidomide and dexamethasone has about an 80% response rate in the relapsed and refractory setting in patients, all of whom had lenalidomide disease that had grown through treatment. So that's, I think, a very exciting finding. What we'd like to get to in the future, and this is, I think, where the session later today will focus on, is whether we can identify additional rational targets on a per-patient basis that would allow us to maximize the benefit. So I'll be reviewing some of the data. One of the interesting targets there is cyclin-dependent kinase 5, and this was identified by Keith Stewart and his group. And there's actually an ongoing trial looking at bortezomib and dexamethasone with dinaciclib, which is a drug that hits CDK5 in addition to other targets. And the theory would be that if the laboratory studies are true, the combination would be better than just bortezomib and dexamethasone and may actually be able to overcome resistance. Another area that's been interesting, and this is Roger Tiedemann's work, has been looking at the development of bortezomib resistance as a phenomenon of outgrowth of earlier types of precursors of plasma cells, which maybe look more like B cells. And so treatments that work against B cells may be helpful there. And then we have data that we're going to present as well, which actually compare bortezomib sensitive and patients who have, unfortunately, bortezomib resistant disease. And one of the pathways that we pulled out actually is the JAK-STAT pathway, and upstream of that is EGFR. So this actually gives us potentially two targets to go after. One is the epidermal growth factor receptor, and of course there are several inhibitors of that that are already FDA approved, for example, in lung cancer. And the other one would be one of the JAK inhibitors. And we have Janus kinase inhibitors that have already been approved, for example, for myelofibrosis. So we think that we have now some rational combinations that we could target to specific patient subtypes. And that would help because it would improve their outcomes and therefore give them longer duration of benefit. What we're finding is that, of course, in each patient, myeloma isn't just one clone. It's a couple of different types of clones, and they respond to chemotherapy. So what we need to do in the future is do very comprehensive profiling of the myeloma cells at the time of diagnosis, look at their genes, which ones are on, which ones are off, treat accordingly, and then probably repeat that testing later on to see how the disease has adapted to the treatment that we've used, And then as new types of myeloma emerge, we're going to have to adapt our treatment to fit that. And I think that kind of approach will get us to the point where we can hopefully cure people.